Good evening and welcome to Doctors on Call. What would you like to know about the diagnosis and treatment of lower GI problems like constipation, colitis, diverticulitis, and colon cancer? I'm Dr. Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth. And I'm pleased to welcome our panelists this evening, Dr. Waldo Avello, a gastroenterologist with St. Luke's Gastroenterology Associates, Dr. Daniel McKee, a gastroenterologist with Northland Gastroenterology Associates, and Dr. Jon Reich, a gastroenterologist with Essentia Health. Answering our phones tonight, we have our medical students, Carter Duncan from Kensington, Minnesota, Dan McGuire from Grand Rapids, Minnesota, and Jared Verrier from Osakis, Minnesota. Now onto the phones, get them ringing, 218-788-2844 locally or toll free at 877-307-8762. And now on to tonight's program. Dr. Reich, you're the new person with us tonight. Welcome to Duluth and welcome back.
Thank you.
I guess we've known each other for some time and some time ago at the University of Minnesota here in Duluth. But at any rate, you're down at Essentia. Do you want to tell us just a little bit about yourself and your practice?
Sure. So I just finished my fellowship at the University of Minnesota, but did my first 2 years of medical school here in Duluth, and now I'm back and loving every minute of it. But I'm a new general gastroenterologist at Essentia Health, and I treat really just about any kind of gastrointestinal disease, although I do have a focus on inflammatory bowel disease primarily.
Dr. McKee?
I'm a general gastroenterologist as well. I've been here in Duluth for a little over 25 years. My office is at the Lake Walk building, but I also have outreach clinics in Virginia and Two Harbors.
Very good. And Dr. Avello?
I'm a gastroenterologist at St. Luke's Hospital. I've been here for the last 15 years, relocated here from Florida 15 years ago. Very happy to be here in Duluth where the weather is much cooler. We are a group of 3 gastroenterologists currently at St. Luke's, and we practice in all the realms of gastroenterology.
Oh, very good. So, realms of gastroenterology. Dr. Reich, what is gastroenterology? And how do you get there?
Gastroenterology is a very, I would call it broad field of medicine because it involves several organs, including the esophagus, stomach, intestines, colon, pancreas, liver, gallbladder, and others. And it's really the diagnosis and treatment of disorders of all of those areas. But also, in addition, we do a lot of procedural interventions for folks. We do colon cancer screening. If folks are having bleeding internally, people are having blockages related to their liver. It's really a broad field of medicine, and so there's all kinds of things that we do.
Dr. McKee, tonight we're focusing on the lower GI tract. So could you just kind of help me and our listeners understand what the lower GI tract is?
Well, Ray, the lower GI tract is simply the rectum and the colon or large bowel, and we might add the very lower part of the small intestine, which is called the ileum. So it's a fairly limited part of the digestive tract.
So while the ileum, so Crohn's disease kind of falls which side? Is that above or below? Is that?
Well, Crohn's disease, you can have it pretty much everywhere in the intestinal tract, but most of the time, at least 50% of the time, you're going to find it in the area of the terminal ileum. But certainly you could have colonic involvement, small bowel, the stomach, very rarely in the esophagus, but the Crohn's disease can involve both the upper and lower GI tract.
What is the most common problem that you fellows take care of in the lower GI tract? Any one of you can jump in.
I think with regards to the bulk of our work is really in the intervention field, mainly in the endoscopy field. So we do a lot of colonoscopies. And probably the most common finding on colonoscopy is diverticulosis. That's one of the things that most commonly seen.
Dan, you were going to jump in.
Yeah, I was going to say, Probably the most common thing we do is with colonoscopies is remove colon polyps to prevent colon cancer. That would probably be the number one thing.
Since the colonoscopy has been widely used, I guess I'm trying to decide or come up with the right word, but widely used, there's been, at least I've perceived that there's been a difference in our colon cancer, new colon cancers, and that there's been a lot of change in that disease. Is that true?
You mean a decrease?
Yeah, a decrease in numbers.
Yeah, it's going down. It really is a success story. There's a decrease in the rate of colon cancer in this country of 3% a year, and that's been going on for the last 10 or 15 years, which is, I mean, it may not sound like a lot, but those 3% add up, and that's really a unique success. If you look at other cancers that we screen for, like breast and prostate, the success just isn't there, but we've made big inroads in terms of the number of colon cancer deaths in this country. So and that's really due to colonoscopy and polypectomy, removing the precancerous lesion.
Dr. Reich, are there other ways? There are a lot of people that want to go through that prep. That prep's not so fun. Are there other ways to evaluate the colon, or is that really the best?
There are other ways, and most patients do tell me that the prep is by far the worst part of their colonoscopy experience. There are some stool tests that can be done that look at the essentially microscopic amounts of blood in the colon, which when you folks have large precancerous polyps or early colon cancers, they tend to have little microscopic bleeding, and so these tests pick that up. And there's a newer test even that picks up DNA, chromosomes from advanced polyps, as we say, in early colon cancer. And so the idea behind these is to throw out a broad net and capture as many people who have this microscopic blood and DNA in their stool, so that if that turns positive, folks should know, if they're going to do this kind of screening, that if they have a positive test, then they come for a colonoscopy, because that's when we do most of the good work in taking polyps out and identifying things.
Question comes in. We're getting good questions already. Hemorrhoids, what are they?
Hemorrhoids are veins primarily in the rectum, at the entrance to the rectum. They're clusters of veins that most people that have had, particularly women that have had children, people that suffer from constipation will oftentimes have these dilated veins, very much like the varicose veins that you get in the legs. These are varicosities in the area of the rectum.
Dan, I think you brought it up. Maybe you didn't, as polyps, but diverticuli. What is diverticulitis? Somebody wants a plain answer to that.
Well, diverticulosis is the presence of pockets or outpouchings in the colon, largely from not eating enough fiber. Diverticulitis is when one of those pockets ruptures and causes infection.
John, when you're doing a colonoscopy, the full length, when you get all the way in, you're at the cecum, is that correct?
Right.
Someone's asking the question, during a colonoscopy, if the scope cannot pass the cecum, what is the next procedure? What do you do then to go up to this? We're getting up into the small ball now.
Right. Well, usually on a colonoscopy, if we need to, and sometimes routinely, you can advance the colonoscope into the small intestine to have a look, into the ileum, as we say, because usually if we can get the colon, you can almost smoosh it up on itself like an accordion when we're doing a colonoscopy, and you have extra camera left to even get a good look up into the small intestine if we need to. But if you have to go very far into the small intestine, there are other things that can be done, including putting a balloon on the end of a scope. It's a little more of a challenging procedure, or even having someone swallow a pill that has a video camera built in, and it takes pictures all the way through the small intestine to see the parts that are more difficult for us to get to.
That work pretty well?
It works well. It takes about 4 pictures a second. It's got a flash. When we sit down and look at it, it is not the most exciting movie to watch, but it does catch, I would say, most abnormal findings in the small intestine.
I think it's particularly good for bleeding. If you're looking for active bleeding, it's a good way. Sometimes, and then on the other hand, if there is no active bleeding, oftentimes you're not going to see, the source, and that's one of the indications in which we use the capsule endoscopy.
Is that thing directionally, does it go directionally or
It's tumbling.
just tumbles its way through
Yep.
and flashes away? Dan, you're quizzical. You got something to add to that?
No, not really. I mean, it randomly takes pictures, but it relies on the fact that it takes them so quickly that it usually doesn't miss. I mean, usually it will see what there is to see.
And of course, the problem then is if you find something that's within the reach of the colonoscopy, the colonoscope, you still got to go back up and do what you have to do,
Right.
generally.
Right, but remember with that capsule camera, you're looking at the small bowel.
Right,
so
you're seeing the other end.
yeah, and it's not likely to be within the reach of the colonoscope. So what you're likely to find is something that's going to require a more difficult procedure, a small bowel endoscopy with a very specialized type of small bowel endoscope, which is a fairly difficult procedure, usually requires a referral to a specialty center that has this very special type of very long instrument to reach deep into the small intestine.
But the capsule also shoots pictures of the large bowel as it comes through too, doesn't it?
There's a separate type of capsule for doing colon
Okay,
capsule
that was
studies.
my mistake.
And it really is not a recommended procedure for example, cancer screening, and it's not done much. The capsule that we're talking about is for looking at the small intestine.
John, chronic constipation and pellet-like stool, is it related to a certain condition, other causes? I need a family doc here. That's why I would have put that one on, but you're
Right.
it tonight.
Well, it's actually, it doesn't maybe sound like it, but it's a bit of a loaded question because, a lot of things depend on how long it's been going on and if it's a brand new change, or, some folks have issues with simply the motility or the muscle function of their colon. In other words, things just don't move as quickly through the colon, and so more water is able to escape. The stools get harder, and hence you get these smaller pebble-like stools. Sometimes there's a blockage at the lower part of the colon that needs to be evaluated with something like a colonoscopy that's just not letting things through as quickly. Sometimes people have muscle dysfunction in what we call the pelvic floor, which are the muscles that support the area around the rectum, that when someone tries to have a bowel movement and strains, things don't come out as they're supposed to. So a lot of things go into chronic constipation.
I think one of the keys to recognize is, a change in bowel habits. So if somebody has been having normal stools all of a sudden develops constipation out of the blue, that's something that it's a red flag that should be investigated.
To take it another direction, we've got another question. What causes diarrhea immediately after eating? Whichever one of you wants to jump on that one.
In that situation, most of the time it's going to be patients that have, what we call an irritable bowel or spastic colon. They have a sort of their gastrocolic reflex is hyperactive. They tend to be people that generally have a hypersensitive gut, and that's a manifestation of the IBS.
Dan, IBS, what is that? Irritable bowel syndrome.
Yeah, irritable bowel syndrome is a very common, what we call functional disorder, as opposed to an organic disorder. So it's defined by a constellation of symptoms rather than, say, something that will show up on a biopsy or a blood test. But the classic symptoms are abdominal cramping that is relieved with bowel movements, altered bowel habits, so there can be either diarrhea or constipation or flip-flopping between diarrhea and constipation. Oftentimes there are other symptoms like abdominal bloating, sometimes mucus in the stools. The symptoms are chronic, but they tend to vary in intensity from time to time. It's much more common in women than men, but like I say, it's a functional disorder as opposed to being caused by, say, an infection or an inflammatory process. And it's something that can be treated, but it cannot be cured.
So John, you're sitting for board soon. How do we treat it?
Well, a lot of the treatments depend on what the symptoms are. And so if someone has primarily constipation, many times what we'll do is try to treat their constipation. We start with things like fiber, laxatives. There's several things. Sometimes we use antibiotic, a specific kind that stays in the bowel. But if someone's having diarrhea, we try to slow down their bowels typically. If someone's having cramping, we have anti-cramping spasm medicines that we can try. Sometimes dietary changes can make a difference. It's really individualized. And you had asked in the beginning what some of the most common things we see in GI are, and we talked a lot about the endoscopy because it is what we do probably 80% of the time. But in the clinic, when we're talking to people, I would say the most common new patient that we see has symptoms of irritable bowel syndrome.
Yeah.
You know, and the question came up from last week's program about the possibility of food allergies also. Someone was concerned about the fact that for many, many years they've been through colonoscopies, seeing docs and dietitians and so on. And we were talking about this a little bit earlier about the food allergies, gluten, and all of the other thoughts. Any ideas with naturopaths and the things that they can do to help too? Wally, you and I are the old ones.
Yes,
here.
and I tell you, the older I get, the more open-minded I become about such things, because I think that with respect to food allergies, we simply don't have the means of accurately testing for that. I mentioned to you the phenomenon with the eosinophilic esophagitis, which is an entity that we recognize now readily, and we see many patients. 15 years ago, nobody talked about. Everybody thought it was a pediatric problem, but it's clearly a food allergy. And I can tell you that as many times as I have sent people to the allergist to be tested for the most common allergens associated with this entity, they always come back negative. So I think that food allergies is a real thing. We just don't have a way to test for it at this point.
Dan, I'm going to switch ulcerative colitis. We haven't touched that. We've
Okay.
beat around. Want to talk about that just a little
Yeah.
bit? And this person's question is, it's been 15 years since diagnosis. Asymptomatic, how often do they need a colonoscopy?
Yeah, whether it's asymptomatic or not isn't so much the issue. It's the fact that they've had it for 15 years. So it depends how often we do a colonoscopy, or when we start doing colonoscopies for cancer screening, and that's the issue here. Folks who've had ulcerative colitis for an extended period of time have an increased risk for colon cancer. So we start doing regular colonoscopies, regular being every 1 to 2 years after they've had the disease for 8 years if it involves the entire colon. If it involves just a segment of the colon, probably around at 12 years. So this person, even without knowing if they've had it in part of the colon or the whole colon, at 15 years they're due for regular colonoscopies every 1 to 2 years. And then what would happen in this case is biopsies would be done throughout the colon, even in normal appearing areas. Multiple biopsies would be obtained to look for precancerous changes.
John, we touched a little bit before the show on fecal transplants. And I think at least tell us a little bit about what that is and where that is at the present time.
Right. It's a fascinating topic, and there's all kinds of theories and hypotheses and interesting things that we're finding about how this, what we call the microbiome, or all the bacteria that live in our colon, which there are more of those than stars in the sky. It's really an amazing environment, and how little alterations in that can affect someone's health. But as far as mainstream at this point, the most common indication in GI is for when people have recurrence of an infection called C. diff, Clostridium difficile. And essentially what happens is typically someone goes on antibiotics, the bacteria in their colon decrease, and then the C. diff can take over kind of and cause an infection. And if we resupply the gut with good bacteria, it can knock that C. diff out and essentially eradicate it, or at least keep it from causing infection there. But there's all sorts of interesting studies about using it for things like obesity and diabetes, and the fact that potentially people with certain kinds of microbiota may be at increased
What's
risk.
biota?
Microbiota, bacteria in the colon,
gut.
sorry,
Okay.
might be at increased risk of certain cancers even. And so, it's a kind of a infant field of research, but it's really exciting.
Wally, autoimmune diseases like rheumatoid arthritis, do they affect the GI tract?
Well, there's certainly autoimmune diseases do not spare the GI tract, and with regards to rheumatoid arthritis, there's oftentimes overlap with some of the inflammatory bowel diseases like Crohn's and ulcerative colitis. The ankylosing spondylitis, and a variety of other autoimmune diseases that involve the GI tract. So oftentimes we get calls from the rheumatologist requesting a colonoscopy on somebody that they're seeing for arthritis, because that arthritis could be just an extra intestinal manifestation of their colitis, and so that's there's definitely overlapping there.
Thank you. Dan, what is short gut syndrome, and what can you do about that?
Well, short gut syndrome is when something has occurred that has resulted in loss of a significant amount of the small intestine, and as a consequence, the individual has difficulty with absorption of certain elements of their diet. And a common cause of that could be Crohn's disease, and then the need for multiple surgeries and having multiple resections of the small bowel. Another possibility would be if there is loss of blood supply to an area of the small intestine, and infarction that causes resection of the small intestine. It could be a devastating condition, and because there is no effective small bowel transplant to replace the loss of small intestine. In its milder form, you can use what are called elemental diets with a type of tube feeding, which is easier to absorb than regular food. But in its worst case scenario, it needs to be treated with TPN, which is an IV type of nutrition. So it can be very, very serious.
Thank you. John, Levator ani syndrome, what is it? Is there treatment, causes?
So the levator ani is one of the pelvic floor muscles that essentially relaxes and contracts along when folks have bowel movements, and can be sometimes the connections with the control of this muscle and how people are trying to have bowel movements and defecate. They can not really, what they want to do doesn't really correspond with what the muscle does. And so and it can be painful, and it can just cause difficulty with defecation or having bowel movements. And sometimes one of the first line things, and this is something that I don't actually see that much, but setting for what's called biofeedback or essentially physical therapy of the muscles of the pelvic floor to try to regulate that better.
Wally, 21-year-old with colitis, coffee and spicy foods a factor or not?
With ulcerative colitis, which colitis?
It just says colitis.
I think that with regards to that, what I usually ask the patients is, does it bother you? Pretty much individualized. I don't really have any specific restrictions with colitis as far as food.
Yeah, I think in general, I don't think the colon knows whether you're drinking coffee or eating spicy foods. By the time it gets to the colon,
That's a good point.
it's not spicy food anymore, and the coffee's been absorbed. So,
You have to individualize it, basically.
For any one of you, is there an easy way to clear up the mucus buildup in the rectum after bowel resections? And I'm not aware of that one, so I have
yeah,
no
I'm
answer
not
to
either.
that.
People ask about mucus a lot, and one thing I tell patients, you tend to see mucus a lot of times in IBS, but mucus is normal. First of all, it's just a lubricant and not generally an indicator of of disease state. And so I think I would, in that case, just reassure and say, don't worry about it.
Very good. We have a lot of questions that we didn't answer tonight. This has been really a good program, and thank you very much for all the call-ins. I have to apologize that we didn't get to a lot of questions, and some are still for upper GI too. I want to thank our panelists for this evening, Dr. Waldo Avello, Dr. Daniel McKee, and Dr. Jon Reich, and our medical student volunteers on the phone, Carter Duncan, Dan McGuire, and Jared Verrier. Please join Dr. Ruth Westra next week for a program on women's health, when our panelists will be Dr. Adi Bakari, Dr. Melissa Miller, and Dr. Mark Widstrom. Thank you so much for watching. Good night.